I'm Dr. Erica Bove, and welcome to the Love and Science podcast. I'm your host, and also the founder of Love and Science, Thriving Through Infertility. I'm so excited you're here today. With over a decade of experience helping thousands of women just like you, I empower professional women to build their families with confidence and compassion. Let's dive in. Hello, my loves, and welcome back to the Love and Science podcast. I get a lot of questions every day, actually, about the difference between fresh and frozen embryo transfers and, whether one is better for certain situations, for what different protocols look like. And I wanted to spend a few minutes talking about how I think about who should get a fresh versus a frozen embryo transfer. And maybe this will shed some light on your situation. So what I wanted to say is historically, fresh embryo transfers used to be all that there were, right? So people would undergo an egg retrieval, those eggs would be fertilized by sperm, those embryos would grow in a laboratory setting, and then the lab person would, sort of in the REI would put in several embryos with the hope that at least one would take. And success rates back in the day were in like the single digit percentages. And so, when I talk to my embryologist, who is, sort of a seasoned embryologist and has been here since the very beginning, he said if you had told him way back when that we would have like a 65 to 70% chance per euploid embryo, that nobody would have believed that's possible, right? And so just for some perspective, people would put in what there was. There, really weren't even supernumerary embryos in the beginning. And if it worked, it worked. And if it didn't, maybe people did another cycle. But then there was the ability to freeze embryos. And, our technologies keep getting better and better. Excuse me. Success rates for, IVF keep getting better and better. And so that does afford the opportunity either to freeze embryos at the outset or to go back to the tank and take embryos out in the context of a frozen embryo transfer cycle if the fresh transfer doesn't work. So let's start with frozen embryo transfers in 2025. Who are frozen embryo transfers really meant for? Well, first of all, if you are undergoing IVF for any genetic reason, in most settings, we cannot really have the turnaround of biopsying an embryo and then doing an embryo transfer in that same cycle. And so if anybody is doing, PGT for monogenetic disorders or PGTA, really those cycles are freeze-all by definition, because we are taking the eggs, fertilizing them, growing them out in a lab, biopsying them and freezing them, and then waiting to get the genetic data before returning to do a frozen embryo transfer. Now, there are people who have said, well, I'm preparing my, uterus, and I know I'm doing a PGT cycle, but I have this euploid embryo in the freezer. Can I transfer it? Yes, you can absolutely do that. But I will say that in my experience, sometimes we do more aggressive stimulations for people undergoing IVF for genetic reasons, because we know we are freezing all, because we know that our goal really is embryo generation. So we're trying to get as many eggs as possible as is safe for the person. Sometimes we allow the progesterone to rise a little bit in that context. And so, even though we can do it, everything really has to be, perfect/ideal to be willing to thaw a very precious embryo and put it into a stimulated environment. I will say that. So anybody who's doing IVF for genetic reasons really will need a frozen embryo transfer cycle. What else? If anybody has like a risk for OHSS or ovarian hyperstimulation syndrome, that is another reason why we might consider doing a freeze-all. There's some data that suggests that for PCOS patients that frozen embryo transfers actually have higher success rates. And maybe that's because the estrogen levels can get over 4,000, or sometimes the progesterone levels start to rise a little bit. But, not for everybody with PCOS, because all PCOS is not the same. But there are some PCOS patients for whom it may make sense to do a cycle, get as many embryos as possible, like Lupron trigger, and freeze all those, embryos once they're, of freeze maturity, of, sort of quality to freeze, and then return in a different cycle under very controlled circumstances to do a frozen embryo transfer. Also endometriosis, we know that endometriosis has estrogen receptors, and sometimes Doing a stimulation cycle can cause like almost like a mini flare. Some people actually have significant pelvic pain during their IVF cycles if they have endometriosis. And so sometimes it's beneficial to actually do the retrieval, generate the embryos, freeze them all, give somebody Lupron suppression for 2 to 3 months to calm the endometriosis down, and then to return back and do a frozen embryo transfer, under very controlled circumstances. And there's also times where people want to embryo bank. So say somebody sees me for the first time at 39 and they want 3 children. Most people are not going to have 3 children from one IVF cycle. So, if somebody gets pregnant, they're kind of out and they can't do another retrieval cycle. So embryo banking is a reason to do freeze all until somebody has a, sort of sufficient, which is a tricky word to use, but a sort of a number they feel comfortable with in terms of embryos in the freezer, and then move forward with a transfer once that's done. And then also, if some pathology is found during the stimulation cycle itself. So, most of us are pretty meticulous about an up-to-date cavity evaluation, but for people who maybe it's been a year-ish, and then we might see a polyp on their ultrasounds, sometimes the most prudent thing to do is actually to freeze all in that situation, even though it wasn't recommended, and then move forward with a transfer after the pathology is removed. Also, in the context of an IVF cycle, if the progesterone starts to rise, that's a situation where a fresh transfer is likely to be less successful. So we might freeze all in that situation, like unexpectedly, right? But then in the name of having a more successful transfer when the labs are looking better. So those are reasons why we might think about doing, a frozen embryo transfer sort of as the first line. Now, why might we do a fresh transfer as the first line, right? I think we've all gotten very, I would even dare to say, obsessed with genetic testing of embryos. I think maybe the pendulum has swung a little bit too far, especially with everything we know now about mosaicism. I think that especially for younger women, PGT outcomes are actually worse when you look at, PGTA versus untested embryos. So I think we really do need to be cautious when we're thinking about PGTA. But, there are some people who really have a hard time making blastocysts, and most labs, I think my lab at the University of Vermont is an exception because our lab director is very experienced at day 3, freeze thaws. However, many, many labs will actually, not freeze at day 3 embryo just because their outcomes are not as good. And so if somebody, decides to do a transfer on day 3, well, at least that embryo is inside of their body and has the chance to keep developing in their body. And studies are ongoing. This is a question we really haven't sorted in our field yet. But there are some people where, I truly do think that they have a day 3 transfer. Maybe that embryo would have been barely a morula in our lab, right, which is not even fully a blastocyst, but it continues to divide inside the body, it implants, and then it makes a baby. So there are embryos that would not meet freeze quality on day 5, day 6, but are able to be transferred either on day 3 or day 5, day 5 really, either of those two, and they actually do make babies. So I want to mention that, being a fertility specialist, wanting to give everybody the best shot they can have at having a family, we never want to be discarding normal embryos or embryos that are potentially viable. That's like really not favored upon. But I do think that if we enforce this like strict freeze-all criteria on everybody, we probably are doing that. So just to keep an open mind about that. I think that there's like this thing that we can do kind of in a hybrid circumstance where, say, somebody's like 37, 38, they want a fresh transfer, but they also want to know what's frozen. If they're not pregnant with that, cycle, or say they do get pregnant, they still want to know what's, sort of there with more detail. And so I don't recommend this in young patients, but if somebody's like 37, 38, 39, they want to do a fresh embryo transfer and then do PGTA of the rest, that can be kind of a nice way to blend the two of like getting a fresh transfer in, which of course is better for timing, but then also, having the data of the PGT, especially if people are like 38 plus and that data is important to them. Again, it's not a perfect technology, but the data are definitely more encouraging in older women as compared to younger women. So that's a possibility as well. And then I think about factors that are very practical, like cost and timing. And so, at my center where there's, a decent wait list for IVF, if somebody has a fresh embryo transfer, that's going to be a lot more efficient from a timing perspective than if somebody has a freeze-all cycle and then has to wait, to have a cycle subsequently. And, I will say we have a process for this, so people aren't, sort of at the back of the waiting list. But timing really can be a factor. And especially when sometimes it can feel like so many delays and it already takes so long to get to IVF in the first place, many people want to try as efficiently as possible. And, as long as it clinically makes sense to do so, the most efficient way to do that is to, to put the embryo in when the uterine lining is already ready and primed. Also cost, I don't think we talk about cost enough, but the last time I checked, doing a frozen transfer sort of in addition to doing a sort of regular stimulation cycle was about an extra $2,000 in medications if people pay entirely out of pocket. And so if you think about it, like, the uterus is already primed in a fresh cycle, so you don't need to like spend money on estrogen, spend money on progesterone. Progesterone can actually be quite expensive. But if you are, thinking about it and you are able to save that money, for many people that might be like a vacation or money in investments, or thinking about all the different ways we can spend $2,000 wisely and judiciously. And for other people that's a deal breaker. Many people aren't able to afford an extra $2,000, and that weighs on their decision process. So I guess in summary, what I would say is fresh versus frozen. If somebody, is poor prognosis and really we have a track record of them not making blastocysts, then I think a day 3 fresh transfer is very reasonable. Maybe even a day 5, as long as sort of there is that thought to put the embryo in. But I always say, where's the best place for an embryo? In a reputable lab, it shouldn't matter. But there are some people who do get pregnant with day 3 transfers, and I don't want to, sort of discard that data. So again, we need the study to show what is optimal, especially in poor prognosis patients, poor responders. But in my practice, I always like to put the embryo in on the sooner side, especially if somebody has few embryos and I'm worried about their ability to make blastocysts. Also practical factors like cost and timing for fresh transfer. And then for frozen, if we really need the genetic information for any reason, then it's going to be a freeze-all. Sometimes with endometriosis, sometimes with PCOS, there are some nuances that push us towards frozen. Now, let's talk about frozen embryo transfer protocols for a second. There's a couple of different ways to do it. There's a fully medicated cycle, which is where we keep the ovaries and the brain out of it, and we focus on the endometrium. We give estrogen, either, sort of pills orally or vaginally. There's also patches that we can give, and then some sort of progesterone. The data suggests that in a completely medicated cycle, some sort of progesterone injections, either every day or every third day, are going to be superior than vaginal progesterone alone. So that's been a shift we've made in the last 5 to 10 years based on data. And so fully medicated cycle, estrogen, then progesterone transfer, and then those hormones are continued until about 10 weeks, usually. There's some practice variation, but till about 10 weeks until the placenta is sort of comfortably taking over at that point. Now, there's been this rise in natural cycles and modified natural cycles, and there's as many protocols, it seems, as there are people. I think what's important to remember is that these protocols are based on a typical menstrual cycle, and there's different ways to do it. Some people do like follow somebody's menstrual cycle if they happen to ovulate every month, and then they put the embryo in at the right time and give no supplemental hormones. I'm not so trusting of the ovaries, so I don't typically do that unless somebody is like very, very crunchy granola and they really want nothing else than that. I'm always meet people where they are, but my preference is to use a little bit of sort of support. And so I often will use letrozole, which is a aromatase inhibitor that helps to stimulate ovulation. We track ovulation. And then, once we see a nice follicle of sufficient size and a thick lining and a low progesterone, then we use the trigger shot usually to then cause ovulation. And so then those ovarian hormones are starting. And then we can even give supplemental luteal hormone support to augment that. So that's sort of my protocol of choice for natural cycle FET. There's also some women for whom the way that they make their best lining is gonadotropin. So the gonadotropins act on the ovaries make multiple follicles, kind of like an IVF. The downside of these sorts of cycles is that there's no retrieval at the end of the day. So like if you do a fresh embryo transfer, at least you've taken out a lot of those granulosa cells. Although, when you are doing a gonadotropin FET, all those follicles are still intact. And so you can get hyperstimulation syndrome from this. I want to be very mindful about that. But if there's no other way that somebody's making an adequate lining, or that's where their lining looks the best, then I will often do that, obviously with caution. And so those are basically the different protocols. If somebody has a history of chronic hypertension or preeclampsia, there are some data that the maternal outcomes in this way are actually better when you look at sort of lower rates of preeclampsia and such with natural cycles compared to fully medicated cycles. And so we do look at that data. Also, if somebody has a very restricted schedule, the fully medicated cycle is going to be better because you start with a transfer date and then you work backwards, versus the modified natural. It often can lead to like multiple monitoring appointments at the very end. And then, finally, when it's like ready for a trigger, then somebody comes back roughly a week later for their transfer. So, sometimes it's like 3 daily appointments in a row. And, most people who are working full-time jobs, that can be hard to negotiate, even though I always advocate negotiating for these sorts of things. I've had like surgeons and other sort of really busy physicians who have a hard time making all those back-to-back appointments. And some people take a leave and they make it work. But I will say the sort of the least amount of disruption to the schedule is going to be with the fully medicated cycle under most circumstances. So I hope that was helpful. I think as we go on with time, we may even be seeing more protocols and different variations and novel therapies, especially as pertains to like thin lining and intrauterine injections, maybe PRP. This is such an exciting time in terms of reproductive research. I just returned from ASRM conference, and I feel so inspired by how much groundbreaking research is still happening, even despite the cuts in funding to women's health research. There's so much inspiring research going on, looking at all the different things you would think about in the different areas of reproductive medicine. So I do think this is one of them. I think we're going to continue to see advances with time. And I don't think the story's over. So just as the IVF success rates have gotten so much better in the last 40 years, I think those rates are going to continue to improve, especially with the research that's ongoing. So I hope this was clarifying. I hope you understand this topic a little bit better. And like I said, I'm always up for new suggestions in terms of more sciencey topics to talk about. And you know how much I love you. Until the next time, bye. Thank you for listening to the Love and Science podcast. I'm so glad you joined us today. If you found this conversation valuable, if you could please rate, review, and share this podcast with your trusted people, it would mean so much to me. If you want more tools to help you navigate the fertility journey, please book a discovery call with me today. The link is in the show notes. Please do not let infertility have the final word. I'm here to take the burden from you so that you can achieve your goal of building your family. In gratitude, this is Dr. Erica Bove. I'm rooting for you always.